All right, everyone. Thank you so much for joining. On behalf of the American Heart Association, I would like to welcome you to today's webinar, Race in STEMI. My name is Kathy Thomas, and I am the Director of Registry Research, Analytics, and Measurement for Quality Outcomes Research and Analytics with the American Heart Association. Before we begin, I'd like to quickly review how to use this webinar platform for today's event. At the conclusion of today's presentation, you will receive a link to access today's recording. You will have the opportunity to submit questions to today's presenter in the Q&A section. You may send in your questions at any time, and we'll review the questions during our Q&A at the end of the presentation. Our agenda today includes a presentation from our guest speakers, Asishana Osho and Abhi Goyal, a Q&A between the speakers, and then we will go into a Q&A with the audience. And again, you can submit your questions at any time via the Q&A section. Dr. Osho is a surgeon in the Corrigan Meehan Heart Center at Mass General Hospital and an assistant professor of surgery at Harvard Medical School. He specializes in adult cardiac surgery, heart failure, and thoracic transplantation. He earned a BA with high honors from the Oberlin College, an MPH from Yale University School of Public Health, and an MD from Duke University School of Medicine. He completed residencies in general and cardiothoracic surgery at Massachusetts General Hospital and Harvard Medical School. Dr. Osho conducts clinical, translational, and health services research to understand and improve cardiovascular health across various populations. He also has significant experience designing and implementing clinical trials in cardiothoracic surgery. His research projects have been supported by the American Heart Association, the Thoracic Surgery Foundation, and Intuitive Surgical, and the Society of Black Academic Surgeons. Dr. Goyal is an academic cardiologist and clinical investigator who serves as professor of medicine at the Emory School of Medicine, professor of epidemiology at Emory Rollins School of Public Health, and chief quality officer for the Emory Heart and Vascular Center at Emory Healthcare. He is responsible for directing all quality-related initiatives in the Emory Heart and Vascular Center, including providing physician oversight for Emory Hospital's participation in the American College of Cardiology National Cardiovascular Data Registry, American Heart Association Get With The Guidelines CAD Registry, and Mission Lifeline Program for patients with acute heart attacks. The Emory Clinic's quality improvement initiatives pertaining to cardiovascular performance measures. Dr. Goyal serves on a number of American Heart Association and American College of Cardiology committees, is an active clinical investigator, and has over 120 published manuscripts. And I will now turn it over to Drs. Osho and Goyal for today's presentation.
Thank you very much, Kathy. And I do want to use the opportunity to thank you and your team from the registry and the data science group for all the support through our work and the collaboration. I think I speak for Abhi and myself in saying that we just couldn't have done it without you. And we're just always impressed by how well, how quickly, and how efficiently everything was done. I'm going to pull up my slides here and we can get started. All right, I think we've got slides up. So Kathy's done a very nice job at introducing us. I won't repeat that, but I am grateful for the opportunity here to talk about some of our work exploring race in STEMI care in the United States using the American Heart Association Get With The Guidelines registry. Discussing disclosures, we don't really have anything relevant to this conversation except that we don't have all the answers yet. And we look forward to discussing this and learning more from all of you as we go through. So the Get With The Guidelines registry, Coronary Artery Disease, is a disease registry that's been designed to support acute myocardial infarction, CAD, and really improvement activities around any management of chest pain across the United States. And one of our goals here is to help you as a crew understand the benefits of and the strengths of the registry and how it has helped us in what we think is very important work. The study that we conducted, which we'll focus on through this presentation, is this one. It was published in Circulation last year, and it's race-based differences in ST elevation myocardial infarction process metrics using the Get With The Guidelines registry in just over 175,000 patients. And then the goals of the talk today, as I mentioned, would be to give an overall sense of the strengths of the registry and how it's empowered our work. I do plan to start by helping us as a group sort of discuss and go through some of the evolutions of STEMI quality metrics, help us appreciate the existing disparities in STEMI care leading up to our work and some of the things that set us up for the studies that we did. I want to share the work that we did, our findings, implications for patient populations in the future, and certainly talk about some opportunities for improvement and action in the future. So to jump right in, there's a whole generation of science leading up to the early 2000s and really end of the 90s that started to demonstrate that the speed or urgency of revascularization following a myocardial infarction event is important. And there are several studies showing that patients who get faster revascularization have better outcomes. And in about 2006, the Door to Balloon Alliance was launched with the goal of improving the rates of achieving door to balloon times in less than 90 minutes at 75% of cases. So essentially wanted 75% of patients in the United States to achieve those numbers. This was rolled out and launched by the American College of Cardiology. And that target was achieved pretty quickly in about 2 years, in part because of the energy and the coalition that was created around this metric. And beyond 2008, there were further improvements in the outcomes. So by just before the initiative was started in January 2005, the median door to balloon time was 96 minutes. And in 5 years later, by 2010, it was down to 64 minutes. In terms of the specific attainment of the target of less than 90 minutes, we went from 44% of patients achieving this to over 90%. And if you push this further, and went even stringent to setting a goal of 75 minutes, you see that by 2010, over 70% of patients in the United States who are part of the appropriate registries were achieving these metrics, which is just absolutely incredible progress in a field that hadn't seen much progress leading up to that point. The AHA Mission Lifeline STEMI Systems Accelerator project was rolled out shortly after this in about 2007 and really worked in a synergistic way to improve some of those statistics that we talked about. The program here did put some emphasis on the time before presentation to the hospital. And this focused on patient education, early recognition, and early acquisition of a 12-lead EKG by EMS teams before they got to the hospital so that they could pre-warn the ED and cardiology teams to be ready to perform PCIs. And what resulted from this over time was further improvement. So, going from 2010 to 2016, that there were faster patterns of referral to PCI capable centers, and in part due to some of the work that was done by the Mission Lifeline program. And this also translated to time to PCI intervention for patients, which went from a median of 88 minutes in 2010 to 79 minutes in 2016, and within the registries. That, again, testament to some of the work that's been done by our societies on these issues. In the background of all this, though, and even prior to a lot of these interventions, there's been an acknowledgement and recognition in science that there are differences in outcomes based on gender and race and ethnicity. This paper, published in 2005 in the New England Journal of Medicine, used the National Registry of Myocardial Infarction patients and looked at about 600,000 patients between 1994 and 2002. And tracking the colors in this graph here, the top one represents white men, purple is white women, and then yellow and blue, which are overlapping, are black men and women. And obviously you can see that there is a separation in the rate of reperfusion therapy by gender and by race, with Black patients having significantly lower rates of reperfusion than the others. Now, the graphs improve over time, but they're parallel to each other, showing that the improvement that we see is not, while all groups are getting better, the disparities are maintained throughout. This study was done by Cram and colleagues, published in 2009 in the Journal of National Medical Association. And this took Black patients and tried to remove the impact of insurance, because obviously socioeconomic status is so intertwined with race in this country and plays a part in how the type of care and the quality of care that people receive ultimately. But this study looked at 430,000 patients separated into unique insurance groups, and then explored how people did over time the rates of revascularization by race. It's focusing in this third group here. You see that if you take all the race groups together, that there is still increased rate of revascularization, a higher rate of revascularization for patients who are of Caucasian descent, while Black patients were at about 38.3% lower, and Hispanics were at 41%. And this persists across all of the individual insurance groups. So in some ways, separating this from the impact of insurance. The study also looks at CABG patients, and then combines the impact of PCI and CABG, and the story holds throughout. Patients from underrepresented minority groups receive revascularization at lower rates than patients from majority groups. And further into this science, this particular study focused predominantly on Hispanic patients who had lower populations than other studies, but looked specifically at some of these process metrics that we'll discuss, the use of ambulances, the use of pre-hospital EKG, and time to achieving PCI. And just going right to the bottom row here, again, compared to the majority group, patients from the Hispanic populations had door-to-balloon times achieving the 90-minute goal that were lower than majority patients. So only 70% of the time did they achieve that, versus numbers that are close to 80%. And this is across the board, where patients from the majority group are essentially doing better across all metrics: higher rate of ambulance use, higher rate of pre-hospital EKG, faster times to getting an EKG once they arrived, and so on and so forth. Specifically in the Get With the Guidelines registry, Dr. Camander and colleagues published a study in 2013 that explored door-to-balloon time stratified by race for patients who were included in the registry. This was about 8,000, just over 8,000 patients total. And this study actually provided some things to be encouraged about. So this is the median door-to-balloon time stratified by race, and the numbers are still different. 74 minutes for white patients versus 77 for Black or African American patients, and then 75 for patients of Hispanic descent. But the magnitude of differences was demonstrated in this paper to be decreasing with time, and one could argue or start to see that there is improvement over time, and the differences here they're not astronomical. And similarly, for the percentage of patients who attain goal times for door to balloon, the percentages were higher for patients of white descent versus African American and Hispanic, sort of paralleling the white group. But what we see is that those magnitudes are not that bad, and this provided some potential room for encouragement that despite differences, all tides were being lifted by our initiatives, and maybe in future iterations we would see that there was further progress. Which brings us then to our particular study, and as we thought about the opportunities to innovate and to push the envelope here, there are a few spaces that we thought were ripe for this. One was that, the guidelines in 2013 from the ACC-AHA had looked at time to intervention numbers and continued to recommend that patients get intervention within 90 minutes. But a change was that the request had essentially changed from door to balloon to FMC to device time, which is, again, going back to that graph that showed that there's an emphasis now on even the pre-hospital portion of this, because there's so much that the emergency medical services could do to improve how quickly we treat our patients. So this really gave an opportunity to look at what we thought was a novel metric, the FMC versus door to balloon time, which itself had not been studied. I discussed that last paper by Kavanagh and colleagues that showed some progress, and in all honesty, we were excited to further push this and see whether maybe now with time there had been some evidence of further elimination of disparities across groups. And then there was a big opportunity to explore the added and improved data in the Get with the Guidelines registry. Many of the studies were robustly powered, but not as robustly powered as ours, and there was room there to really make a contribution to the literature. So going forward, we designed our study with the hypothesis that compared with white patients, Hispanic and Black patients would have a lower likelihood of achieving key STEMI process metrics, and a higher likelihood of in-hospital death. But this time looking to adjust robustly for age, comorbidities, acuity of presentation, insurance, and socioeconomic status. This was designed as analysis of prospectively collected data through the Get with the Guidelines registry, as highlighted. We looked at patients between January 2015 and the end of December in 2021. This represented a unique unstudied time period, if you would. It would be an advancement on prior data, and in some cases was curated by the data quality and the needs from the database. We looked at all adult patients presenting with STEMI only, and looked at several race and ethnicity groups. The focus for us was on white, Black, and Hispanic patients, and this was done for power reasons. These were the groups that were mostly well populated. The database does have other ethnicities, including Asian American Indian, Alaskan Native, Native Hawaiian, or Pacific Islanders, and in a group that's unable to be determined or other. It is worth noting that race data in the database is entered from the electronic medical record, which is either reported directly by patients or family members, or entered by hospital staff, presumably and hopefully following consultation with patients, but realistically suspect that isn't always the case. The study outcomes were predominantly process metrics. FMC, first medical contact to PCI, being the first, and achieving that within recommended goals of less than 90 minutes. We looked at the rate of pre-hospital ECG. We looked at the door to ECG time less than 10 minutes, and then specifically a door to balloon or door to device time that would parallel prior metrics and help us do some sort of cross-time validity, if you would. And then we looked at a host of secondary outcomes, including length of stay in the emergency department, first medical contact to lab activation, transfer times, and ultimately in-hospital all-cause mortality. A lot of previous data, some which have showed, had demonstrated clear separation of outcomes and of processes by sex. And we wanted to separate that from our present analysis to focus on race and ethnicity. So all our analyses are stratified by sex, and were conducted using hierarchical generalized estimating equations. For our final models, we built things out in 4 stages, if you would, starting with an unadjusted model, and then subsequently models that adjusted first for age, and then what we call a multivariable model that adjusted for age, comorbidities, and clinical status. And then our final sort of most extensive deep models adjusted for everything in the multivariable model, plus insurance and socioeconomic status. That the range of comorbidities and features of clinical status that were adjusted for are available in the paper, but this is everything from whether they had a cardiac arrest prior to arrival to underlying comorbidities like diabetes, peripheral artery disease, cerebrovascular disease, creatinine function, and really the full spectrum of things. It's worth spending some time to discuss how we use how we adjusted for socioeconomic status. And this paper published in 2022 by a group that included Dr. Goyal and some of our collaborators looked at county level social vulnerability and the association between that and major adverse cardiovascular events in patients who are hospitalized with COVID-19. And the approach to exploring socioeconomic status used this concept of social vulnerability and a social vulnerability index, which was developed by the Centers for Disease Control and Prevention through their Geospatial Research Analysis and Services program. So social vulnerability is defined or essentially refers to resilience of the community, its ability to survive and thrive, particularly when confronted by external stressors on human health, such as natural disasters, human-caused disasters, or other kinds of outbreaks. And essentially, the thought is that reducing social vulnerability can decrease human suffering and economic loss. Specifically, populations that are thought to be socially vulnerable include those who have special needs, and folks who don't have stable transportation needs, folks with disabilities, people with limited English proficiency, older age, things like that. In this particular study, which I'll discuss the steps of getting from SVI to a form that's usable for analysis, the authors explored social vulnerability index in quartiles as predictors of outcomes for patients hospitalized with COVID. And what they show here is that it basically is graded in that folks who have lowest social vulnerability were least likely to die when admitted for COVID-19, and those who had the highest degrees of social vulnerability in the right here had the highest mortality from COVID-19. And this also translated to composite outcomes, in this case, a MACE outcome that included mortality and a few other factors. Now, SVI is designed in the original form anyway, is designed based on US Census Bureau data, and it captures multiple variables, including information on socioeconomic status, housing composition, language, and housing type. And these factors are then used to create a nationwide ranking of counties with higher numbers representing higher vulnerability. So if a county was in the 99th percentile, it would be, more vulnerable than 99% of counties across the nation. And these are the different pieces that go into social vulnerability and the index that's estimated by the CDC. So that there's pieces related to socioeconomic status, including poverty level, unemployment, income, and education level. And then there are things related to housing composition and disability. Then minority status and language are a category of their own, and then there's a focus on housing and transportation. And what I think is incredibly powerful about this is that there are levels to the SVI in that each of these independent 15 or 16 domains is ranked separately. There's a percentile number for each of these, so you could take the status of single parenthood and try to understand whether that unique variable has an impact on outcomes. However, you can then use it as a composite score that takes into account all of these pieces and take that percentile or into groups like was done in that prior paper to to understand the impact on people's lives and health. Like I mentioned, SVI is a county level variable, and to get from the CDC SVI percentile to being able to use it with the registry, it required a crosswalk of zip codes to census tracts or counties, which is available through the U.S. Department of Housing and Urban Development. So it does require some statistical gymnastics to convert it from county codes to zip codes. And zip codes are available in the AHA Get With the Guidelines CAD registry, which we then use to incorporate at the patient level into each of our analyses. So coming now to our study population, over the dates that I highlighted, 2015 to 2021, is about 483,000 patients at 711 hospitals. Following the initial exclusions for age, any missingness in race, ethnicity, or gender, the population decreased a little bit, and then further we further curated based on patient presentation. Folks who were not STEMIs or STEMI equivalents were also excluded, and this brought our population to about 193,000. The final study population managed for some hospitals that didn't have complete data, but also we previously discussed how some race and ethnicities weren't populated in a robust fashion, and those patients were excluded, to bring our final study population to about 178,000 at just under 700 hospitals. Our baseline study characteristics, again, are available in the paper, but the numbers broke down to by gender to about 41,000 white women, 3,000 Hispanic women, and 7,500 Black women. And then on the male side, there are about 103,000 white men, about 10,000 Hispanic men, and about 14,000 Black men. The age distribution was a little disparate across the groups, with the oldest populations existing in the Caucasian group. But ultimately, these were adjusted for in all our models. It's worth noting too that for the multivariable models, both for process metrics and for our survival, the populations were limited a little further to about a 3-year period to allow for as complete data sets as possible for the multivariable analysis. We did have a decent amount of missing data, and continuous variables that were missing were managed by simple imputation of the median, and categorical variables were managed by imputation of the mode, or the use of multiple imputation via chained equations. So jumping right into our study results, what I've done here is I've taken, and I'll go through each specific gender across the races through several of our process metrics to demonstrate the differences. So starting here with the performance of a pre-hospital ECG, but presuming by the EMS team, the solid white box represents Caucasian patients. We have Hispanic white patients in the stripes, and then Black patients in black. And what you see is that there is a higher rate of performance of EKG prior to arrival at the hospital for patients of Caucasian descent. Lowest in this case for Hispanic patients, and then Black patients somewhere in between. But these differences were statistically significant. And this persisted in our extended multivariable models. This is adjusting for age, comorbidities, clinical status, insurance status, and socioeconomic status, and all demonstrated that even with robust adjustment, there's still differences with patients of Caucasian descent being the most likely to receive an ECG across or prior to getting to the hospital. And just as a spoiler, this was a trend essentially throughout all our process metrics. So this is the door to ECG time, less than 10 minutes. Again, in women, white women were most likely to achieve this at 65% versus 60% on average for Black and Hispanic women. And for men, 76% of white men were likely to get an ECG within 10 minutes. And that number was only 66% in Black men. Again, robust adjustment for just about everything, socioeconomic status plus demonstrated that this persisted. Door to device, and I'll hop straight down to FMC to PCI as well, and similar trends that amongst the white women, the rates of achieving FMC to PCI within 90 minutes was highest, 49%, as low as 40% for Black women. And then for men, it was 56% for whites. And actually, the Hispanic men were very close and a little bit higher in this study, but then Black men are down to 50%. And once again, adjusting fully for age, socioeconomic status, comorbidities, insurance status, demonstrated here that Black men were least likely, Black patients, men and women, were least likely to achieve these goals, while Hispanic patients actually equaled or looked slightly higher than patients of Caucasian and Black heritage. We then extended these to mortality models. So with the thought being, now we've seen that there are differences in process metrics. Do these necessarily translate to differences in mortality? And what I've done here is, this is just in women, and going from left to right, it starts with the raw mortality rate for that population, but then looks at models sequentially adjusting for more and more features. So in our unadjusted model, that there seemed to be a signal for Hispanic women to have a higher rate of mortality after treatment for STEMI. And this actually has persisted with about a 40% higher rate of mortality for Hispanic women following robust adjustment. This did not persist for Black women, or this pattern did not show for Black women. And essentially the statistics don't suggest any difference compared to white women. And then switching the focus to male patients amongst the Hispanic population, that there didn't pan out to be initially anyway, in the fully unadjusted model, there was no difference in mortality for Hispanic white patients compared to white patients. But what initially looked like a signal after adjusting for age was subsequently dissipated in robustly adjusted models. And there was no mortality difference for Black patients compared to white patients. So by way of summary, our study results suggested that there is a persistent disparity based on race and ethnicity in the achievement of process metrics for STEMI care. And an important piece of this is that the robust adjustment for social vulnerability index suggested that this was not explained by socioeconomic status. An important piece for us to keep in mind. The next step from this is that our mortality findings suggested that only Hispanic women seem to suffer a mortality deficit related to this, and it potentially suggests that there's limited implications for in-hospital mortality, but this doesn't tell the full story, as you know, patients do live beyond the admission, and understanding the effect on long-term mortality might be something that we need to do. Unfortunately, it's just limited with this particular database. Most concerning and worth spending some time thinking about as a society, as a specialty, is whether or not there's been some regression in progress that we've seen in prior studies. And in that in particular, I think is something to think about as we design further interventions for the future. Well, like any study, ours is not perfect. There are limitations in some of the designations, as I mentioned. This is the designation of race and ethnicities is pretty rudimentary, and it doesn't actually tell you whether or not this is what the patient wanted. It's pulled out of the medical record, so there's potentially some provider input into that, if you would. We didn't have data on language, which I think could potentially be a contributor in this setting. And then there are a few measures of trust and the cultural elements of it that factor in, you know, historical engagements with the medical system. The study was limited to centers that were enrolled in the Get With the Guidelines registry, so that itself has some limitations. And then, you know, with SVI, we make some generalizations first across census tracts and then across zip codes, and obviously not everybody in each zip code or zip code lives at the same economic level or at the same degree of vulnerability, if you would, which is the limitation in the work that we've done. So thinking about the future, you know, I started by talking about all the wonderful work that programs like the Door to Balloon Alliance and Mission Lifeline had achieved. And I think that it'd be important as we design future programs to lift everybody, to make sure that there's equitable distribution of these programs across populations. And in this particular project, we haven't included other underrepresented minority groups, but certainly pulling everybody along will be critical. Certainly, future work should explore the impact of language and culture and historical relationships with the medical system. That there certainly is an opportunity to look at longer-term outcomes. We didn't see a difference in mortality in this particular study, but we only looked at in-hospital mortality, and there might be a signal down the line related to the differential treatment of patients. And then we haven't done much at the provider level, and progress through process metrics is all about the people who are doing them and education and how they're applied to different patients. So being able to think about these things and study them at the level of the provider will be important in the future. So I'll put up the goals again. I was hoping to provide some discussion of the evolution of STEMI metrics, help us appreciate the existing disparities vis-a-vis our study findings and results, and then ultimately discuss some opportunities for action and improvement in the future, with the global goal of really showing the capabilities of the Get with the Guidelines registry and how it's allowed us to be successful in asking these types of difficult but important questions. There's a lot of acknowledgments in this study, and I mentioned Kathy's team and Wendy and the entire AHA data science and registry research teams were central and crucial in getting us to this analysis, to explore it as thoroughly as we did, and couldn't be more thankful for them. Thankful to my co-authors, especially Dr. Goyal for his mentorship, and also Marcelo Fernandez, who's a classmate from Duke Medical School and wrote the initial proposal for this with me. And thankful to the circulation editorial team that worked with us to get the paper published, and ultimately to the registry once again for the opportunity to do this study. That's all I have. I know Dr. Goyal is still on. I will stop sharing for now, and we can go through some questions together.
Great. I'm going to toggle between saying Dr. Osho and Asishana from familiarity, but it's certainly meant with all respect. Dr. Osho, thanks so much for that terrific presentation. And can I get a thumbs up that I'm being heard okay here?
Yes.
Okay, thank you so much. I'd like to echo your initial comments that we are privileged to have had this opportunity to work together and to work with our AHA colleagues, including Kathy Thomas and her data analytics team, and all of the administrative support from the AHA. It's wonderful that American Heart can support research like this that really matters in terms of disparities of care. These questions have been asked, and a series of papers, including this analysis, have shown it. And it gets some attention, some media attention, and some traction. It may not be as exciting as ongoing discovery work in terms of what's pushing the overall field forward, but it's incredibly, incredibly important. And I just hats off to AHA for really shining a light on ongoing disparities as part of their mission. So that's thanks to AHA. So now I guess we'll get into the Q&A part of this, where part of the remaining time, I'll start by asking you a few questions, and then we can, of course, open it up to our attendees. Also want to thank all of the attendees for taking time out of their day to hear about this important work. And, from an analysis standpoint, you went over the results, and we looked at process metrics, and we looked at mortality. And what you showed is that when you looked at 4 main process metrics, the rate of obtaining pre-hospital ECGs, door to ECG time within 10 minutes of arrival for walk-in patients or for those who did not have a field ECG if they came in by EMS, door to balloon time within 90 minutes, FMC to balloon time within 90 minutes for field patients. All of these metrics were not as good, or there were lower odds of achieving all 4 of these process metrics in Black men, Hispanic men, Black women, Hispanic women, compared to white men, white non-Hispanic men, and white non-Hispanic women. And yet, it seems like the difference in in-hospital mortality was observed only in one of these 4 groups, Hispanic women. So, I guess the first question is a 2-part one. How do you explain the discrepancy in our findings of the process metrics and the mortality metrics? And then, the implication is, do we not have to worry about the disparities in these process metrics if it doesn't make a difference in terms of in-hospital mortality? What is your take on this?
Yeah. Thanks, Abhi. It's a great point, and I think that there are 2 aspects to it. One is the sort of the statistical part of it, which is one is that we started with a broad population and had to corral that down for our really robust metrics to favor data completion, and you wonder if that process changed the way things look to some degree. The other part of it is no matter how well you adjust, there's bound to be some degree of unanticipated confounding that you can't measure. So while we take that data to be true, as you know, that there's elements of it that we haven't accounted for, and I wonder if that might have, if we could create the perfect model, that might show us the things that we really need to see. The other part of it is I will say that I think they're important, and the other part of it is that the outcome that we're looking at in hospital mortality is limited. Lives continue after folks leave the hospital, and you wonder if the delay to treatment or a change in the type of treatment that someone receives changes the trajectory of their life, not over the course of the 2 weeks or month they spend in the hospital, but long-term mortality and long-term morbidity. And I think that's truly where the money is. This database doesn't allow you to do that, despite all its other strengths. And I think we have to get creative about different ways to look at that specific degree of outcome.
Great, thank you very much. I'm going to ask a related question that I see in the chat. I'll sort of toggle between a question I have and related in the chat. Ms. Cecilia Schmidt asks, with the Hispanic population, could delays in care be related to language barrier? What are your thoughts on that?
Oh, absolutely. And if we're looking at metrics in particular that related to the first time folks show up or interact with the medical community, if you would, whether it's EMS or when they show up at the door, you have to anticipate or expect that there are indeed differences in how patients are able to engage and how quickly they're able to engage with the medical system and the language that they feel most comfortable with. We haven't looked specifically at language in this database, but I think there are opportunities, and one potential is SVI does break things down at a rudimentary level, but into comfort with English, for example, is one of the pieces there. And I think that's ripe for exploration to see whether that particular piece has an impact on outcomes. But I strongly suspect that for the Hispanic population, there's a language piece to it. And related to that, I think culture, of different races and ethnicities in different regions also factors in. And I use culture to mean willingness and excitement to engage with the medical system, which could lead to delays in calls and delays in answering questions or really disclosing your true range of symptoms to patients, or even in the threshold for demonstrating pain or or symptoms. And I think all these factors play a big part.
That's great. Thank you, Shauna. I'd like to just also expand on one other benefit I have observed directly in working with our American Heart colleagues is they take the feedback from the analyses seriously, and they truly make an effort to integrate the findings and translate them and implement them in the registry programs. So, for example, the question that Ms. Schmidt asked about the language barrier, in part as a direct result of our findings, one of the feedback we received from peer reviewers and from colleagues was just that, that we did not collect data on preferred language of the patients, and that certainly can contribute to delays in care. And because of that, we are systematically looking to include preferred language in the Get With the Guidelines registries and the suite of registries. And I believe that's already implemented or very soon to be implemented in the suite of registries. And so that is a real gratifying piece is under the Get With the Guideline registry program, there is the opportunity to directly translate our findings and the gaps into enhanced data collection, and really looking forward to seeing that additional data with preferred language moving forward.
Absolutely.
All right. I'm going to ask you what might be a little bit of a uncomfortable or hardball question, but I think it needs to be addressed. And that has to do with the possibility that is there possibly structural racism in healthcare delivery or among healthcare workers that could contribute to findings, in our paper. So what are your thoughts on that? That's often the soundbite implication of papers like this is you be scientific and you try and adjust for different factors, clinical factors, and zip code and socioeconomic status, education, all of that. And then, one can't help but wonder after all is said and done, is there a possibility of structural racism? And if so, what can we do about it? What are your thoughts in this arena?
Yeah, definitely a tough question. And I agree with you, one that we need to be thinking about. On a global level, structural racism is essentially everything in society that contributes to these different outcomes. And I think some of this is reflected in our findings. The folks from the underrepresented groups were amongst the highest in terms of social vulnerability. And as noted, these involve domains including language and education and economic factors. And I think in that regard, the structural racism that comes with those differences is almost undoubtedly affecting the outcomes and the care of these patients. And then there's the other level, which is, in my mind, the hardest bit, which is the part that requires introspection from each of us as a provider, which is to what degree is my bias or my personal relationship with people affecting the care that they receive. That there's a lot of descriptions about how some degree of implicit bias exists in each of us, and in some ways this is due to structural racism because this was an evolutionary thing that we developed as humans and was part of the way we thought about things. But it doesn't necessarily mean that it can't be addressed. And I think it behooves all of us to take a step back when you read something like this, or certainly for us, when you do an analysis like this, to think about yourself in particular and think about how my personal implicit bias could be contributing. And the science to try to investigate this at the individual provider level is it's been done. There's an excellent study in the New England Journal of Medicine from several years ago that performed surveys of folks at a cardiology conference, over 700 physicians, and presented patients from different races and ethnicities with STEMI presentations, and there was a differential rate of diagnosis in that setting based on the race of the individual patient that was sold to the interviewee, if you would. And I think data like that will continue to help us all recognize our implicit biases and help us work as a group to address these. But yeah, tough one, and tough to think about personally, and certainly tough to discuss, but at any level.
All right. We have a little under 10 minutes here, and there are a couple of, looks like there's some other questions that are in the chat. Let's see here. There are a couple of questions about the Asian population, and I see that Kathy has responded. You know, the Get With the Guidelines registry actually have really expanded their capture of race within the past couple of years. It is currently being looked at in terms of outcomes of specific groups. For example, if you speak with investigators that look at Asians in particular, it is, from their perspective, questionable whether we should be lumping, for example, all of the Asians under one group. You know, South Asians, Chinese, Korean, Japanese, sometimes Hawaiian and Pacific Islanders. And so for the purpose of this analysis, it was quite a we find that that Asian group is really a heterogeneous group. It's well represented in Get With the Guidelines, but it's quite heterogeneous and required a lot of extra sort of in-depth looking into. And so that is the subject of a separate paper that is ongoing, run by sort of a different set of investigators. I see that Carlos Moreno asks, have you seen better metrics in geographic areas which have higher minority populations versus areas not as diverse? I'm going to take a stab at that here, Shauna.
It's a good question, and I think I don't know if this is the spirit of it, but there's some data and thought that higher rates of diversity and higher engagement of minority populations in areas that are more concentrated empowers the whole population as a group. That is, empowers the whole minority population as a group. And while we haven't looked at it in this particular study, I think it is worth investigation in the future. The thought there would also be that if you've got a more diverse population, that does include medical providers and maybe folks treating people who speak their language or who have some of the same set of cultural beliefs that they have might improve outcomes.
All right. Thank you. Let's see here. There's some good discussion in the chat about extrapolation of data from charts. This is from Marianne Ducey. I can't even get frontline clinical people to capture if the patient right standing in front of them is white or black. Yeah, that's a real that's a great comment. It is, the nature of the workflow. When patients are registered or they come in, oftentimes it's one of the limitations of these types of papers is how is race ascertained, how is ethnicity ascertained. And most studies will agree that the quote unquote gold standard for it is self-reported. How individuals themselves will report their own race. Next to that, you have the healthcare staff or registrars documenting what they may or may not see in front of them. That may be better than documenting nothing at all. but you can imagine it gets pretty tricky when we have patients who identify with more than one race or ethnic group. And so that's right, it's an ongoing, it requires ongoing work. Let's see, we have a question in the lobby chat I see here from Sophie letting us know, what about onset to FMC? What about ejection fraction? So onset, so I think what I'm understanding from the spirit of the question is, what about symptom onset to first medical contact? That's a great question. We did not look at that in this particular paper. I think I'd be preaching to the choir for this group. When we look at the continuum of care in STEMI, there's sort of three phases that we look at. And we've historically, in the past 20, 25 years, we've tackled I shouldn't say the easier aspects, but the less complicated aspects first. First we tackled the hospital phase of care, when the patients arrive at our hospital door until PCI or fibrinolysis, depending on where they are. And then this paper and others in the Mission Lifeline and to Get With the Guidelines CD era look at the pre-hospital phase, which is from the time of arrival of the paramedics at the side of the patient until arrival at the hospital. This question about onset to FMC, to me, it sounds like it's addressing the holy grail and the remaining piece, which is symptom onset until the patients call 911 or make the decision, ideally calling 911. That's always preferable to hopping in a car and being transported to the hospital. There's still about 40% of patients with STEMI that will walk in to an ED. But we did not look at symptom onset to FMC in this, and if there are racial differences. Some of that data, we do collect that. Some of it is incomplete by race, and I think we're in a better position to look at that moving forward. The ejection fraction data, ejection fraction was a factor that was adjusted for in the analyses. I believe that, we did look at differences in the baseline characteristics table in terms of how EF distributed among the population. And I see that there was an answer to the question that the paper is available for free download, and you can take a look at the EF data that we have posted there across the racial groups. Sophie Tai has put that in the chat at around 1:45 p.m. A free download of the article that we referred to in this presentation. With that, I think we have, all right, so I think we're at 1 minute left. Kathy, I'll turn it over to you. Or Shauna, if you have any final word, I'll turn it over to you, and then we'll turn it over to Kathy.
Yeah, no, just thanks to everybody for attending. Thank you again, Dr. Goyal, for your mentorship, and thank you, Kathy, for your collaboration. It's great.
Thank you both to our speakers, Dr. Osho and Dr. Goyal, for their presentation today. And I just wanted to say thanks for everyone for their time and attendance on today's webinar. And we will very shortly be sending out a recording to the webinar. So we appreciate it, and have a great rest of your afternoon.
Thank you.
Thank you.